Good afternoon, everyone. Today we will present a clinical case titled Ventricular Decoupling when the Structural Impacts the Functional. I'm Lorena Villalba, a cardiologist at the Cardiovascular Institute in Buenos Aires, Argentina. This was a 53-year-old male patient who has hypertension, dyslipidemia, is sedentary, and a smoker as cardiovascular risk factors. His only cardiovascular history includes a hypertensive crisis 15 years ago. He was being treated with valsartan 160 milligrams daily as antihypertensive therapy. The patient consulted the emergency service due to epigastric pain at functional class 4, radiating to the back and chest with an intensity of 8 out of 10, accompanied by sweating and nausea. The patient's physical exam revealed clear-headed with no motor or sensory deficits, with arterial hypertension, blood pressure of 210 over 110 millimeters of mercury, differential pulse between the upper and lower limbs, with a heart rate of 70 beats per minute and normal peripheral pulses, with normal heart sounds, no murmurs, and good airflow without extra noises. Among the complementary studies requested, an electrocardiogram was performed where we can observe a sinus rhythm of approximately 65 beats per minute, showing a leftward axis deviation and intact AV conduction, indicating left ventricular hypertrophy and ventricular repolarization abnormalities. A frontal chest X-ray shows an increased cardiothoracic index, slight widening of the mediastinum, a straightened aorta, and clear costophrenic angles, with no lung field abnormalities. In the laboratory analysis, as a positive finding, we can see a slight leukocytosis and a negative ultrasensitive troponin T. Additionally, a bedside echocardiogram was performed where we can see a long axis view from the left sternal border, where we see a left ventricle with wall thickness within normal limits and good wall motion, with good motion in the anteroseptal and inferolateral walls, without major valvular changes. In the adjacent image, we see the ventricular measurements that are within normal limits. In the image below, we can see the dimensions found at the level of the aortic root, which showed a maximum intersinus diameter of 25 millimeters, which when adjusted for body surface was 24.5 millimeters per square meter. And the maximum diameter measured at the tubular portion was 43 millimeters, and adjusted to its surface area was 23.2 millimeters per square meter. In the following clip, we observe a short axis view at the level of the major vessels, where the tricuspid aortic valve is visible, with slight fibrosis of its valves. In the image to the right, there is a 4-chamber view where we observe that the wall motion, both inferoseptal and lateral motion of the left ventricle is preserved. And in the next image, we see an apical 2-chamber view showing the inferior and anterior walls of the left ventricle, which is also the motion preserved. It can also be stated that the ventricular function seems to be intact. Considering the symptoms and these positive findings regarding the dilation of the aorta, and suspecting a possible acute aortic syndrome, a CT angiography of the aorta was requested, thoracic and abdominal, and here we see an acquisition without contrast, which is the first step to take when suspecting acute aortic syndrome. to check for an intramural hematoma. In this patient, we observe an image in a hyperdense crescent form in the descending aorta, well at the origin of the artery, just posterior to the origin of the left subclavian artery, which aligns with an intramural hematoma. In this video, we are looking at the arterial phase of the angiography sequence where we highlight the intramural hematoma, and approximately 45 millimeters from the superior mesenteric artery, there is a dissection character which covers the entire abdominal aorta, dissecting it both anterogradely and retrogradely. The tomography report informed us that an intramural hematoma of the thoracic aorta was present, descending, which begins at the level of the left subclavian artery's opening and runs along the entire thoracic aorta, decreasing the vessel's diameter by 50%, and a dissection flap that involves the entire abdominal aorta, dissecting it in both directions. This dissection extends to the level of the inferior mesenteric artery. There was also a dilation of the aorta at the sinus level of the ascending and descending aorta. During hospitalization, the patient experienced uncontrollable pain and refractory hypertension to medical treatment, and a chest X-ray indicating pleural effusion, leading to the choice of surgical treatment and a bypass of the left subclavian and carotid arteries with a prosthesis, and a stent was placed in the descending aorta with a flap at the origin of the artery, at the subclavian artery's origin. Subsequently, the patient was discharged and 5 months later returned to the emergency department due to sudden onset chest pain radiating to the neck, rated as 8 on a scale of 10, lasting 3 hours and transfixing. Given the previous history of a recent aortic syndrome and the characteristics of this new pain episode, a CT angiography is requested to evaluate the thorax and abdominal aorta. We identified a retrograde type A aortic dissection. Consequently, an emergency surgery is performed, replacing the ascending aorta. Using a Dacron tube prosthesis of 26, the arch was replaced, and the brachiocephalic trunk was also reimplanted with Dacron, with a proximal Dacron to the ascending aorta. The patient subsequently evolves favorably with follow-up from cardiology outpatient department. In 2019, the patient was admitted for a planned endovascular treatment due to a type 1B endoleak and a thoracoabdominal aortic aneurysm measuring 52 by 51.5 millimeters of diameter. Therefore, the initial procedure involves placing a stent in the descending thoracic aorta, and 3 months later, the patient was admitted to place a fenestrated EVA with angioplasty to the left renal artery and to the superior mesenteric artery. The patient, 6 months after this hospitalization, evolved with progressive symptoms of dyspnea for 1 month in functional class 2, which worsens to class 3 in the last 72 hours with significant swelling in the legs, and an X-ray indicates vascular congestion. Consequently, the patient shows signs of congestive heart failure. A transthoracic echocardiogram was then performed, clearly showing significant changes compared to the previous echocardiogram, which happened when the aortic dissection occurred, and in this clip we can see a long axis view of the left ventricle, which is clearly dilated with thickened walls, and in addition of these thickened walls with decreased motion, both at the anteroseptal and lower lateral segments. The mitral valve showed a bivalvular tethering due to ventricular remodeling, and the aortic valve with fibrocalcification of its leaflets. In these clips, we can clearly observe a significant decline in the left ventricular function with severe global hypokinesia, and we can also see a dilated right ventricle with deterioration of its ventricular function. Therefore, the final report of the transthoracic echocardiogram concluded that the left ventricle was dilated with significant hypertrophy and with a severely reduced left systolic function. The ejection fraction measured by biplane sinus at 25% with increased filling pressures of the left ventricle with biatrial dilation with a dilated right ventricle with systolic function deteriorated with moderate aortic failure and high blood pressure in the lungs. For this reason, initially, treatment for heart failure is conducted using diuretics, administered endovenously, and nitrates without requiring inotropic drugs, showing favorable evolution. And we initiated the ethological examination of his dilated cardiomyopathy, which presented a new deterioration of the ventricular function. A cardiac catheterization was conducted in which there were no significant coronary lesions. A scintigraphy using bisphosphonates was carried out, and it was negative results for amyloidosis. A negative Fabry test. Serologies for Chagas and viral infections were negative, and there was an inability to perform a cardiac MRI because of significant artifacts from the prosthetic material. Therefore, taking into account his medical history of heart issues and multiple surgeries in the aorta while excluding the leading causes of ventricular dysfunction, the hypothesis for this clinical case was that the most likely etiology is due to aorto-ventricular decoupling. This is our diagnosis. We can see in the images a transthoracic echocardiogram before showing, or in the first admission from his aortic dissection, afterward, during follow-up, the resolution of his aortic disease with the placement of endoprostheses in his native aorta, and his current echocardiogram where we can see this clear drop in ventricular function. As previously mentioned, replacing the native aorta with less compliant prosthetic material increases aortic impedance, causing aorto-ventricular decoupling, which causes ventricular dysfunction due to increased afterload. There are currently several studies demonstrate this effect in terms of ventricular function, ventricular mass, and the systolic work of the left ventricle. Therefore, at the Cardiovascular Institute, a study was carried out, an observational retrospective study where the aim was to evaluate whether endovascular treatment of the descending thoracic aorta is significantly related to worsening ventricular function measured by transthoracic echocardiogram and nuclear medicine during the 1-year follow-up, and within the individuals recruited between 2009 and 2020, 44 patients were included, of which the average age was 69 years, 77.3% were hypertensive. 70% had dyslipidemia, and 63.6% were previously smoker. And what was done was these 44 patients were evaluated using echocardiography. transthoracic before and after the intervention, after the placement of the endoprosthesis, and in the 1-year follow-up, the left ventricular ejection fraction was 62%, approximately before, and after the procedure it was 52%, with at least 1 year of follow-up indicating a statistically significant difference with a p-value of 0.001. Obviously, this study has its limitations as it is a observational study at a single center with a small number of patients, thus it cannot be extrapolated to other types of patient characteristics. As a final message, we know that heart failure has an estimated prevalence of 1 to 2% in the adult population. It is also the primary cause of hospitalization among older patients aged 65 and older. The main cause is coronary heart disease, followed by various hereditary and congenital heart diseases, as well as infiltrative and metabolic conditions. And it is known that in some cases the etiological diagnosis ventricular dysfunction in patients with heart failure can be a significant challenge, and a complex case analysis, especially done by a multidisciplinary team of cardiologists and surgeons, may be essential for achieving the correct diagnosis. It's clear that the normal function of cardiovascular system requires proper coupling between the heart and the aorta, and we believe it is necessary to pay attention and closely monitor ventricular function using echocardiographic and other methods. For patients receiving aortic replacements of several segments with synthetic prostheses, evaluating the risk of ventricular aortic decoupling as an additional cause of ventricular dysfunction and heart failure in these patients. Thank you so much.